A patient is crashing. The initial fluids are in, the first-line vasopressors are escalating, and the blood pressure continues to drop. At the bedside, intensivists use the term refractory septic shock to describe this exact moment. But historically, that diagnosis has relied entirely on subjective clinical gestalt, a feeling that standard therapies are failing rather than a quantifiable physiological metric. This table of historical definitions from the medical literature reveals the extent of the inconsistency. Clinical trials have classified patients as refractory using maximal norepinephrine dosages ranging anywhere from 0.2 to almost 4 micrograms per kilogram per minute. This infographic highlights the fallout from that diagnostic chaos. Without a uniform definition, it is impossible to accurately synthesize research data, establish patient prognoses, or write standardized clinical guidelines. To solve this, the Society of Critical Care Medicine and the European Society of Intensive Care Medicine convened 56 global experts to build a unified consensus. The result is this 4-quadrant framework, moving the diagnosis from subjective observation to an objective, measurable threshold. We will deconstruct these domains: tissue perfusion, vasoactive therapy, fluid resuscitation, and diagnostic modality, to see exactly where true refractory status begins. Because isolating pure, persistent tissue hypoperfusion requires stripping away the multifactorial noise of the ICU. The first requirement of the consensus is objective evidence of inadequate tissue perfusion, despite initial resuscitation efforts. The experts mandate the presence of persistently elevated serum lactate, but they deliberately refuse to establish a specific numerical cutoff. The panel split between thresholds of 2 and 4 millimoles per liter. High lactate is also severely confounded by alternative causes in critically ill patients, like underlying hepatic dysfunction, mitochondrial distress, or seizures. When lactate is ambiguous, the consensus validates capillary refill time exceeding 3 seconds as the globally accessible clinical surrogate for poor tissue perfusion. This table details the final consensus votes. Statements 8 and 9 confirm agreement for lactate and capillary refill time, but the precision relies on exclusions. Statement 14 explicitly rejects central venous oxygen saturation, or SCVO2, from the definition. SCVO2 presents a U-shaped mortality curve in septic shock. A low level indicates poor cardiac output, but an abnormally high level indicates an inability of the cells to extract oxygen. It is too unreliable to define the absolute extreme of shock. Urine output was also rejected. Acute kidney injury, diuretics, and osmolar excretion independently alter urine production, completely decoupling it from actual tissue perfusion. Traditional bedside proxies break down in extreme shock states. Measuring refractoriness demands direct evidence of metabolic distress at the tissue level. The second domain shifts from cellular distress to hemodynamics, the absolute magnitude of vasoactive support required. The consensus dictates a strict, unified metric, norepinephrine base equivalent, or NEE. By utilizing NEE, intensivists can calculate the pharmacologically active component of their treatment, standardizing the math across global variations in vasopressor choices and different salt formulations. This chart maps escalating dosage ranges. The Surviving Sepsis campaign recommends introducing a second-line agent between 0.25 and 0.5. Therefore, a patient's NEE requirement must sit strictly greater than 0.5 micrograms per kilogram per minute to meet the refractory definition. The panel explicitly rejected defining refractory shocks simply by the number of vasopressors used, as early multimodal therapy is now a common standard of care, not an indicator of ultimate failure. True refractory status is dictated by the absolute depth of the vasoplegia, not a physician's strategic choice to use multiple agents. The third domain tackles volume management, assuming the patient has already received the Sepsis 3 standard 30 milliliter per kilogram initial fluid bolus. The physiological prerequisite here is absolute. The patient must be proven to be fluid unresponsive. Clinicians must use active dynamic tests to prove that pushing any additional volume will fail to yield an improvement in hemodynamics. Continuing to administer fluids to a highly vasoplegic, unresponsive patient only exacerbates extravascular fluid leakage, swelling the tissues to worsening organ dysfunction. A patient enters the refractory category only when their cardiovascular system has definitively lost the physical ability to convert preload into perfusion. The final requirement mandates visual confirmation via critical care ultrasound. At the absolute edges of septic shock, the etiology of hypotension begins to blur. Pumping a patient with massive doses of catecholamines to meet that 0.5 NEE threshold can unmask latent heart disease or directly induce secondary cardiac dysfunction. Ultrasound must be utilized to actively rule out obstructive or cardiogenic causes of mixed shock. A pure distributive shock diagnosis cannot be locked in mathematically. Visual confirmation is required to prove the heart itself isn't failing. This infographic outlines the new baseline. To be classified with refractory septic shock, a patient must meet all 4 conditions simultaneously: objective tissue hypoperfusion, confirmed fluid unresponsiveness, a norepinephrine equivalent exceeding 0.5, and ultrasound confirmation of a pure distributive etiology. This flowchart tracks the methodology that built those pillars. Over 5 Delphi rounds, experts stripped away confounded variables down to 13 stable consensus statements. By adopting this precise phenotype, clinical researchers can finally design randomized controlled trials that enroll the exact same patient populations, allowing data to be accurately compared across borders. For intensivists, it provides a highly specific trigger point, dictating exactly when to abandon standard algorithms and initiate targeted salvage therapies. This consensus establishes refractory septic shock as a rigid, measurable, and targetable physiological state.